Okay, so last we left it, you had just learned about the medical model as it applies to psych disorders. This should be the last thing that we covered in the last video. So, what we're going to move on to today is talking about classifying psych disorders. Because once the medical model was adopted, so too was the belief and the assumption that mental illness was not just a single illness, but actually a bunch of different types of disorders, just like physical illness is not just one physical illness, but it can come in many forms. And so psychologists have come up with various systems that allow them to classify disorders. We're going to talk about the major one today. But the first question is, why is classification important? And so this slide is both about why classification of psychological disorders is important, but it's also just about why, at least those first two bullet points, why classification of anything is important. Why is it important to categorize things and organize them? So, first reason is for description. Um, if you didn't have a classification system for mental illness, it would take a lot of time and wasted energy, probably create a lot of confusion to try to explain what someone's illness was. Because we have a classification system, we're able to use very clear and concise language. You can say, as a doctor, that someone has major depressive disorder, and all of a sudden, the person you're talking to completely understands what you mean. To say that someone has a given disorder, whether it's bipolar disorder or schizophrenia, there are a lot of symptoms that go along with each disorder, and there are symptoms specific to each disorder. And just by saying the disorder's name, that one word communicates a ton of information. So, a classification system allows us to talk about things in an efficient manner, using one or two words to communicate a wealth of knowledge. Classification systems also allow us to predict. If you know that someone has depression versus bipolar disorder, you can know what to expect as their disorder progresses. And I use you as a general sense. I think that for a lot of people, this is more if you have a disorder, you can kind of know how it's going to play out. A doctor would know how it's going to play out. So, classification systems allow us to predict things. It also allows doctors to suggest treatment. You treat depression differently than you treat bipolar disorder. You even treat a major depressive disorder different than you would treat the depression that's part of bipolar disorder, different than how you would treat schizophrenia, different than how you would treat a phobia. So, different disorders are treated in different ways. And so, knowing what disorder someone has, being able to classify that allows us to direct that individual towards the proper or suggested treatment. And then lastly, it allows research to happen in a focused way, as opposed to having haphazard research and an inability to communicate different findings. You can focus on depression or you can focus on schizophrenia, and you can find all of the research that's already been done on that topic because you have this classification system. Now, the way that psychology currently classifies disorders, at least here in the United States, is they use what's known as the DSM-5. Mentioned this earlier, the DSM-5 is the fifth edition of the Diagnostic and Statistical Manual of Mental Disorders. It's published by the APA, the American Psychiatric Association. And to say that it's the fifth edition doesn't just mean that it's gone through five slightly revamped versions. When the DSM publishes a new version, or I guess when the APA publishes a new version of the DSM, it's publishing a drastically updated edition. So the fifth versus the fourth edition are very, very different. There are different disorders, like some new disorders in the DSM-5. There have been some categories that have been moved around. I just want to be clear that it's not a new edition like you might see in a textbook. It's a very meaningful change. In fact, here on this slide, you can see some of the changes between the fifth and the previous version. I in my class wouldn't hold you accountable for this information, but I do think that it gives you an idea of what one addition to the next might look like. So if we go back to our information, on the DSM-5. There are some specific benefits to using something like the DSM-5. The DSM-5 is a manual, so it is a book, although I think now it exists in app form and online, very 2017. But it's a book that allows experts to make diagnoses. And this is helpful for a lot of reasons. Realistically, the DSM-5 allows individuals to receive a diagnosis, which means that their therapy and their treatment can hopefully be covered by insurance. Insurance companies usually require a diagnosis of some sort before they'll reimburse any type of treatment. So for a very real world application, it's important to have a book which allows someone to receive a diagnosis. The DSM-5 enables diagnosis by focusing on describing what a disorder looks like, but it does not attempt to explain how disorders come about. There's actually a lot of different perspectives on what creates disorders. There's actually a lot of disagreement about it. And so the DSM-5 doesn't want to take a side. It doesn't want to say whether disorders are created by brain abnormalities or created by a person's childhood or created by cognitive patterns. Instead, the DSM-5 just wants to say, this is what a disorder looks like. And so that's exactly what you find within the pages. As you saw, it's called the Diagnostic and Statistical Manual. So it has a list of different symptoms that you would see in a disorder. Something like major depressive disorder, it says, 5 out of the following 7 symptoms need to be present for a minimum of, I think it's like 2 to 3 weeks in order to be diagnosed. And then it lists a laundry list, almost like a checklist of just different symptoms. Someone experiences apathy or anhedonia, which would be a lack of pleasure, or a loss of energy. And so there's a bunch of symptoms. And if you meet those very objective, so those completely opinionless symptoms, then you receive the diagnosis from a qualified professional. The DSM-5 presents disorders in this way because it's attempting to be, as I said, objective. It's also, however, attempting to be reliable. The goal of something like the DSM-5 being structured in the way that it is that an individual should be able to go to a psychiatrist in New York, present their symptoms, receive a diagnosis, then go to a psychiatrist in Ohio or in Tennessee or in Hawaii, present the same symptoms, and receive the same diagnosis. So that's the goal of the DSM-5, and it tries to accomplish that by using these very objective, observable symptoms. Now, one of the outcomes of diagnosis is that, of course, it attaches a label to a person that they have this disorder. And we've gone over some of the ways that that can be a good thing, but it can also be a negative because diagnosis does create a certain element of bias. I'm going to link you to a website that if you in the YouTube description on this one, and if you scroll down the website, there's a clip that I think you really should watch. It's part of the Rosenhan experiment, sometimes called the Thud experiment, where a group of people actually got themselves admitted to mental institutions by pretending that they could hear a voice and it was saying the word thud. These individuals were otherwise completely sane and normal. They just pretended they had this one symptom. Then once they were admitted to the hospital, they acted completely normally. They wanted to know, would the doctors in these institutions, this was back in the 70s, would they be able to tell that they really didn't belong in the institution? Or once they received that label, that diagnosis upon entering the institution, would it be impossible for the doctors to see past it? So definitely go watch that video and kind of see what happened. Another example of how a diagnosis can create some sort of bias. Nellie Bly was a journalist who you learned about. She got herself admitted to a mental asylum by pretending to be insane. Once she was in there, she found that it did not matter what she did or how she behaved. There was no getting out of the asylum. They believed very much that she was insane. And so her editor had to actually break her out by writing. And then lastly, people will see videotaped interviews of the same person, but are told different things about that person, that they're either a job applicant or a mental patient, believe very different things about the person. So same video, but believe different things about them.